Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 180 of our Pharmacotherapy MCQ series, which majors in infectious diseases. And the first question reads, PLO, a 34-year-old female patient presents to your venerologist for counseling after a diagnosis of recurrent genital herpes simplex virus type 2 HSV2 infection. She has no significant past medical history. She is HIV negative, but has had 11 herpes outbreaks within the past 1 year. PLO is interested in reducing the severity of outbreaks and decreasing the frequency of the recurrences. So my question to you is, which of the following would be the most appropriate therapeutic recommendation to achieve these goals? Would it be A. Famciclovir 1 gram orally twice daily for 1 day each time a prodrome is noted, or B. Valacyclovir 500 mg orally once daily, or C. Valacyclovir 1 gram orally once daily, or would it be D. Acyclovir 400 mg orally 4 times daily? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Valacyclovir 1 gram orally once daily. Acyclovir 400 mg orally 3 times daily is appropriate for treating a first clinical episode. A regimen of 400 mg orally twice daily is more appropriate for suppressive therapy. Valacyclovir 1 gram orally daily is appropriate for suppressive therapy in a patient with frequent recurrences, defined as more than 10 per year. Valacyclovir 500 mg orally daily is appropriate for patients with less frequent recurrences because it is not as effective as 1 gram orally daily in patients with more than 10 recurrences per year. Therefore, valacyclovir 1 gram orally daily is the better choice for this patient who experienced 11 recurrences in the past 12 months. Famciclovir 1 gram orally twice daily for 1 day each time a prodrome is detected will help reduce the severity of the outbreak, but it will not reduce the frequency of recurrences. Please advance to the next question. And the next question reads, AZP, a 17-year-old sexually active female patient tests positive for cervical gonorrhea in nucleic acid amplification tests as part of routine screening. She was treated for a prior episode of gonococcal infection 36 months ago. With regards to allergies, she had an anaphylactic reaction to ceftriaxone requiring a 2-day hospital stay for observation. So my question to you is, which of the following would be the most appropriate treatment regimen for this patient based on current Centers for Disease Control and Prevention (CDC) sexually transmitted diseases treatment guidelines? Would it be A. Admit the patient, perform ceftriaxone desensitization, and give ceftriaxone 250 mg IM stat plus azithromycin 1 gram orally stat, or b. Azithromycin 1 gram orally stat plus levofloxacin 750 mg orally once daily for 4 days, or c. Azithromycin 2 grams orally stat, or would it be d. Azithromycin 2 grams orally stat plus gentamicin 240 mg IM stat. I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. Azithromycin 2 grams orally stat plus gentamicin 240 mg IM stat. I would like to start by commenting that dual treatment with one-time 2 grams oral azithromycin and 240 mg intramuscular gentamicin doses is the current CDC guideline recommended treatment for uncomplicated cervical gonococcal infection in patients with a history of anaphylactic reaction to beta-lactam antibiotics. Monotherapy with azithromycin would not be appropriate. Azithromycin monotherapy might seem like a good choice for this patient because Neisseria gonorrhoeae strains completely resistant to macrolide antibiotics are not common in the United States. However, this therapeutic approach is not supported by current CDC guidelines. The CDC no longer recommends the use of fluoroquinolones for the treatment of Neisseria gonorrhoeae because of resistance. Please progress to the next question. And the next question reads, TTM, a 35-year-old pregnant woman presents to her primary physician's office with a chief complaint of abnormal vaginal discharge. She is 21 weeks pregnant and her physician makes a diagnosis of cervical chlamydia using a nucleic acid amplification test, abbreviated as NAAT. She is treated with appropriate antibiotic therapy. TTM notifies her sex partner about her diagnosis so that he can also undergo testing and treatment. So my question to you is, which of the following describes the most appropriate follow-up for this patient? Is it A. She should return 14 days from now for a vaginal swab NAAT as a test of cure, or B. She should have a vaginal swab sent for culture and antimicrobial susceptibility testing now to help guide treatment if symptoms return, or C. She should return to clinic 28 days from now for a test of cure using a vaginal swab culture, or is it D. There is no indication for a test of cure, but she should be retested with the NAAT for reinfection 90 days from now. I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. She should return to clinic 28 days from now for a test of cure using a vaginal swab culture. A test of cure using a vaginal swab culture is recommended 3 to 4 weeks after the completion of treatment in pregnant women, although test of cure is not recommended for patients who are not pregnant. Retesting 3 months from now to detect reinfection also is appropriate for this patient. Routine antimicrobial susceptibility testing currently is not recommended for chlamydia trachomatis due to a lack of documented resistance to first-line therapies. The vaginal swab NAAT is not FDA cleared as test of cure. Please progress to the next question. And the next question reads, UDA, a 38-year-old sexually active male patient presents to the STD clinic. He has a chief complaint of sore throat, pharyngitis, and dysphagia. On physical examination the following are noted. The posterior oropharynx is erythematous with a greenish exudate, together with localized lymphadenopathy. A pharyngeal specimen is sent for nucleic acid amplification testing, NAAT, and the clinician plans to presumptively treat UDA now for pharyngeal gonorrhea. So my question to you is, which of the following would be the most appropriate empiric treatment based on current CDC STDs treatment guidelines? Would it be A. azithromycin 1 gram orally stat, or B. ceftriaxone 1 gram IV once daily for 7 days plus azithromycin 1 gram orally stat, or C. ceftriaxone 1 gram IM stat plus azithromycin 1 gram orally stat, or would it be D. ceftriaxone 250 mg IM stat plus azithromycin 1 gram orally stat? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. ceftriaxone 250 mg IM stat plus azithromycin 1 gram orally stat. Ceftriaxone 250 mg IM once plus azithromycin 1 gram orally stat is the current CDC guideline recommended treatment for uncomplicated pharyngeal Neisseria gonorrhoeae infection. Azithromycin 1 gram orally stat is appropriate for the treatment of chlamydia trachomatis. Ceftriaxone 1 gram IV once daily for 7 days plus azithromycin 1 gram orally stat is appropriate for the treatment of Neisseria gonorrhoeae arthritis. Please advance to the next question. And the next question reads, PKO, a 38-year-old sexually active male patient presents to the STD clinic with a chief complaint of dysuria, and urethral discharge. Regarding her sexual history, he recently engaged in unprotected sex with his new girlfriend. A diagnosis of urethral gonorrhea is made and he is treated with the recommended antibiotic therapy. He inquires what his girlfriend should do because she is about to take a flight to the Far East to work at an orphanage for 30 days and will not be able to come to the clinic before she leaves. Given this clinical scenario, which of the following would be the best approach to using expedited partner therapy, assuming that it is legal in the country, for PKO's girlfriend based on CDC STD's treatment guidelines? Would it be A. cefpodoxime 400 mg orally stat plus azithromycin 1 gram orally stat, or B. ceftriaxone 250 mg IM stat plus azithromycin 1 gram orally stat, or C. cefoxime 400 mg orally stat plus azithromycin 1 gram orally stat, or would it be D. expedited partner therapy is not recommended for women exposed to Neisseria gonorrhoeae due to the risk for pelvic inflammatory disease? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. cefoxime 400 mg orally stat plus azithromycin 1 gram orally stat. Pelvic inflammatory disease, abbreviated as PID, is a valid concern because the symptoms are nonspecific and Neisseria gonorrhoeae can cause PID. However, the CDC guidelines state that the benefit of treatment outweighs the risk. The CDC guidelines do recommend that counseling be provided, advising that partners seek medical evaluation for any symptoms of STD, particularly PID. Ceftriaxone 250 mg IM stat plus azithromycin 1 gram orally stat is a reasonable choice, but it is not preferred because of the use of the IM route of administration for ceftriaxone. Cefpodoxime is inferior to cefoxime for the treatment of Neisseria gonorrhoeae. Please proceed to the next question. And the next question reads, TJB, a 35-year-old male patient who received a haplidentical stem cell transplant for treatment of acute myeloid leukemia, abbreviated as AML, presents to your oncology clinic. 16 days after his transplant, TJB develops pleuritic chest pain. His chest CT scan shows a cavitary lesion in the right middle lobe. His pertinent labs include a serum galactomannan assay performed that morning is positive with a value of 1.3. TJB's absolute neutrophil count, abbreviated as ANC, is 0 cells per millimeter cubed. His current treatment comprises of levofloxacin 500 mg IV once daily as antibacterial prophylaxis, acyclovir 5 mg per kilogram IV thrice daily as antiviral prophylaxis, and caspofungin 50 mg IV once daily as antifungal prophylaxis. He also receives routine immunosuppressant and supportive care medications. A prior course of prophylactic voriconazole was stopped due to visual hallucinations. So my question to you is, which of the following would be the most appropriate treatment for TJB's probable invasive aspergillosis? Would it be A. voriconazole, or B. posaconazole, or C. isovuconazonium sulfate, or would it be D. anadulafungin? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. isovuconazonium sulfate. Anadulafungin is inappropriate because this patient developed breakthrough infection while receiving another echinocandin, caspofungin. Anadulafungin is recommended as part of combination frontline therapy only for selected patients. Voriconazole is inappropriate because this patient was intolerant to voriconazole. Additionally, equally effective alternatives to voriconazole are available. Isovuconazonium sulfate is recommended as an option for the treatment of invasive aspergillosis in the 2016 Infectious Diseases Society of America (IDSA) guidelines and as first-line therapy in the European Conference on Infections in Leukemia, abbreviated as ECIL-6 guidelines. Posaconazole is inappropriate because this patient has probable invasive aspergillosis. Although posaconazole is active against aspergillus, no randomized controlled trials supporting its use as frontline therapy have been performed and no guidelines recommend its use for this purpose. Please advance to the next question. And the next question reads, TLC, a 58-year-old female patient with grade 3 of 4 gastrointestinal graft versus host disease, abbreviated as GVHD, following a matched unrelated donor hematopoietic stem cell transplant HSCT for acute myeloid leukemia AML 9 months ago, presents to your transplant clinic. Her current medications include corticosteroid and tacrolimus for treatment of GVHD. Recently TLC complained about increased diarrhea. TLC is admitted to your hospital for treatment of presumed refractory GVHD and evaluation of leukopenia. Colon biopsy is done shortly after admission, as well as viral inclusion bodies. Her serum cytomegalovirus (CMV) serum polymerase chain reaction test is positive with a value of 10,268 international units per milliliter. The infectious diseases team is consulted for management recommendations. Her review of systems is significant only for diarrhea, that is, approximately 6 non-bloody bowel movements daily. Her physical exam is notable only for presence of a double lumen peripherally inserted catheter in the left antecubital fossa. Her chest X-ray shows no acute cardiopulmonary disease. She has a past medical history significant for acute myeloid leukemia, which was diagnosed 24 months ago, matched unrelated donor HSCT 9 months ago, grade 3 of 4 gastrointestinal GVHD and corticosteroid-associated diabetes. Her current medications include tacrolimus 1 mg IV once daily via continuous IV infusion, methylprednisolone 120 mg IV once daily, posaconazole 300 mg IV once daily, acyclovir 400 mg IV twice daily, pantoprazole 40 mg IV once daily, sertraline 100 mg orally once daily, ursodeol 300 mg orally 3 times daily, and loperamide 2 mg orally as PRN for loose stools. Her pertinent vitals include a blood pressure of 102 systolic and 78 diastolic, a heart rate of 98 beats per minute, a respiratory rate of 21 breaths per minute. Her pertinent labs include sodium levels of 132 milliequivalents per liter, potassium levels of 3.9 milliequivalents per liter, magnesium levels of 2.4 milliequivalents per liter, a BUN of 17 mg per deciliter, serum creatinine of 0.8 mg per deciliter, a WBC of 1.2 times 10⁻³ cells per millimeter cubed, with 40% neutrophils, absolute neutrophil count 480 cells per millimeter cubed, and 16% lymphocytes. So my question to you is, which of the following antiviral agents would be the most appropriate for treating CMV colitis in TLC? Would it be A. valganciclovir, or B. ganciclovir, or C. foscarnet, or would it be D. cidofovir? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. foscarnet. I would like to begin by commenting that cidofovir is inappropriate because it is not recommended as first-line treatment for CMV colitis due to a lack of efficacy data and a less favorable adverse event profile compared with other options. Foscarnet is the most appropriate choice because this patient is diagnosed with CMV colitis and has severe neutropenia following HSCT. Ganciclovir is inappropriate because its side effect profile is less favorable than that of foscarnet, and ganciclovir may worsen pre-existing severe neutropenia. Valganciclovir is inappropriate because this patient has severe GVHD, indicating questionable absorption of the drug as well as uncontrolled viremia. Valganciclovir has a less favorable toxicity profile than foscarnet, and it could worsen pre-existing neutropenia. Please advance to the next question. And the next question reads, DKM, a 45-year-old female patient with recently diagnosed acute myeloid leukemia AML is receiving intensive remission induction chemotherapy with idarubicin and cytarabine. She is on day 9 of cycle 1. She has no significant past medical history. And no history of infections. Review of her systems is significant only for nausea and fatigue. On physical examination there are no significant findings. Her current medications include levofloxacin 500 mg orally once daily, valacyclovir 500 mg orally once daily, ondansetron 8 mg every 4 hours, pro-Renata, PRN for nausea, pantoprazole 40 mg orally once daily, cytarabine 100 mg per meter squared by continuous IV infusion on days 1 to 7, idarubicin 12 mg per meter squared IV on days 1, 2, and 3. Her pertinent labs include a WBC of 0 cells per millimeter cubed, a total bilirubin of 0.8 mg per deciliter, an ALT of 38 international units per liter. So my question to you is, which of the following regimens is the preferred antifungal prophylaxis for DKM according to National Comprehensive Cancer Network, abbreviated as NCCN guidelines? Is it A. posaconazole oral suspension, or B. posaconazole tablets, or C. fluconazole tablets, or is it D. caspofungin intravenous? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. posaconazole tablets. Caspofungin is inappropriate because DKM is receiving intensive remission induction chemotherapy for AML, and she is at high risk for invasive fungal infection, abbreviated as IFI. Caspofungin is recommended as antifungal prophylaxis only for patients at lower risk of IFI. Fluconazole is inappropriate because DKM is receiving intensive remission induction chemotherapy for AML, and she is at high risk for invasive fungal infection (IFI). Fluconazole is recommended as antifungal prophylaxis only for patients at lower risk for IFI. Posaconazole tablets are the most appropriate choice because DKM is at high risk for invasive fungal infection due to her receipt of intensive remission induction chemotherapy for AML. Posaconazole is the preferred antifungal prophylactic agent in patients at high risk for invasive fungal infection, according to NCCN guidelines. Tablets are preferred over oral suspension due to greater bioavailability and fewer drug-drug and drug-diet interactions. As the bioavailability of the posaconazole tablets is not affected by the gastric pH, unlike the oral suspension formulation, the use of pantoprazole would not affect the bioavailability of the oral tablets. Please advance to the next question. And the next question reads, OJT, a 37-year-old male patient receiving salvage chemotherapy with fludarabine, cytarabine, and filgrastim, abbreviated as FLAG for acute myeloid leukemia (AML), presents to your accident and emergency department with a chief complaint of blurred vision in his right eye and sinus pain. A consultant otolaryngologist performs an urgent nasal endoscopy that reveals necrotic, bloody tissue. He consults infectious diseases team with regard to management recommendations. His physical examination is notable for sinus tenderness on palpation, periorbital swelling, exophthalmos, and inability to track movement with the right eye. A CT of the sinus shows complete opacification of the right maxillary sinus with mucosal thickening. A CT chest shows innumerable new nodular lesions, consistent with invasive fungal disease. His pertinent home meds include posaconazole tablets 300 mg orally once daily. His pertinent labs include a WBC of 0 cells per millimeter cubed, a serum creatinine of 0.7 mg per deciliter, posaconazole trough serum concentration 1 week prior to presentation was 1,680 nanograms per milliliter. His serum galactomannan is 0.4 negative. So my question to you is, which of the following would be the most appropriate IV antifungal therapies to initiate for OJT's presumed invasive fungal sinusitis? Would it be A. voriconazole, or B. posaconazole, or C. isovuconazonium sulfate, or would it be D. liposomal amphotericin B? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. liposomal amphotericin B. Amphotericin B liposomal is the most appropriate choice because OJT developed a breakthrough fungal infection while taking posaconazole. The physical exam, laboratory findings, and negative galactomannan assay are consistent with mucormycosis. Amphotericin B liposomal is the recommended frontline treatment for mucormycosis. European Conference on Infections in Leukemia guidelines recommend amphotericin B liposomal as the preferred first-line agent for this infection. Isovuconazonium sulfate is inappropriate because OJT developed a breakthrough fungal infection while receiving posaconazole. The effectiveness of isovuconazonium sulfate for treating invasive fungal infection is unknown. Few supporting data are available. Intravenous posaconazole is inappropriate because OJT developed a breakthrough fungal infection while receiving oral posaconazole with an adequate serum drug concentration. Therefore, any pathogen probably is resistant to posaconazole. Voriconazole is inappropriate because the physical exam, imaging findings, and negative galactomannan assay are consistent with mucormycosis. Voriconazole is not effective for treating mucormycosis. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 181.